So then let's talk about hallux valgus. Hallux valgus. Valgus meaning lateral deviation of the distal limb segment. In this case, it's a bunion. Much more simply put, bunions. So as far as our bunions are concerned, I'm just going to scroll through them so I can have it all up on the board. So when we talk about bunions, the first thing to ask about is family history, and that's going to tell you if there's a genetic component to the bunions, because it turns out that bunions do run in the family and there are genetics to them. And if that's the case, then short term, we look at pain management. Long term, probably surgery. However, regardless of whether or not it is genetic or not, footwear is going to aggravate it if it's genetic. And if it is not genetic, footwear can indeed cause bunions. So when we look at our shoes, of course, we have the shape of the shoe, and it's going to be this part. It's called a toe box, right? So the toe box is, of course, where the toes go within the shoe. And what we look at with our toe box is on the inside, the medial side of the shoe, how much does that go lateral? So you see in this shoe, it's actually pretty straight. There's a mild curve to it, but it's only very mild. Sage's shoes are quite straight as well. In fact, you've all got okay shoes as far as the toe box is concerned. Now what happens is if we wear a narrow toe box shoe, which is to say almost every form of running shoe, and certainly dress shoes, high heels, things like that, fancy shoes, oftentimes flats, like a pair of Toms or something like that, they all have a very narrow toe box. And the problem with a narrow toe box day in and day out is it forces the toes into, well, the big toe specifically, into a valgus position. It pushes the big toe out laterally, creating an artificial bunion. You force your feet into poor footwear often enough and for a long enough period of time, eventually you will develop bunions. So even if you don't have genetics, and if that is the case, when they first start to begin, there's definitely a lot we can do about it. We can change the footwear, and we can instruct our patients and clients to wear toe spreaders. Stretch out the toes and then go through toe and foot strengthening exercises. In more chronic cases, not a lot we can do, because by the time we've gotten to the chronic case where we do have a true bunion forming, we can't correct the bone deformity. Observation, so it's quite easy. It's an observational, it's a postural dysfunction. So there's our O in the Holmes P. For palpation, it can be totally painless. However, in more significant cases, you'll see pain, inflammation, tenderness on the outside edge of the first metatarsal. Yeah, it's called a bunionette. Mm-hmm.
Same concept?
Same concept. Yeah, narrow toe box shoes. What you can see with a bunionette is we can see medial deviation of the distal limb segment. So technically the bunionette is going to be, I can't remember the technical name for the little toe right now, it's slipping my mind, but it's a varus stress. So we can see that, but what we also see with the little toe is it rotates. So if you put your feet down flat, all of the toenails should be up, of course, pointing straight up. But you might see with the little toe, it's twisted, where the toenail is pointing out lateral. And that's a bunionette as well. Mm-hmm. Not necessarily, no.
That's more related to lifestyle.
Yeah, bunionettes are pretty much exclusively shoes. Yeah. Now we've got this thing that says DDX, it's differential diagnosis. Differential diagnosis, as we go through it, is going to come up periodically, not every time, because sometimes there's nothing similar, right? But within bunions, we need to be aware of gout. So from your pathology class, you know what gout is. In its most simplistic definition is it's a deposit of uric acid within joints, and in this case, specifically, it would be the first metatarsal phalangeal joint. It's very easy to differentiate gout from a bunion, though. Bunions, at worst, are tender and to the touch. They could be mildly painful, but the reaction of somebody when you're pressing on a bunion is, I'd like you to stop doing that. I don't enjoy that, so please stop. As opposed to gout, Gout in a mild case is, I would appreciate if you stopped doing that. But more often than not, gout is extremely painful, extremely painful. Yes, yeah, gout is diet related, largely diet related. Mm-hmm. So easy enough to differentiate. There's our differential diagnosis. So then that takes us into our our range of motion and special tests. Active passive resistor, there's possible limitation in movement. And it could be flexion extension, it could be abduction and adduction. Essentially with active passive resistant and bunions, there's possible limitation depending on the severity. If it's incredibly severe, yes, there will be painful limitation in all of the motions. However, if it's mild, we won't find any limitation. There are no special tests. Bunions are largely observational. They're largely observational, so you don't really need to perform your active passive resistant. And we're going to finish off our discussion with a few other descriptions. We have hammer toes and Morton's toe. Hammer toes, this is the bottom image. And that's where we get the toes curl up. Now, technically, there's a difference between hammer toe and claw toe, but the difference is meaningless to us. It's essentially where the toes are going to curl. The reasons why, again, largely it's going to be footwear. However, there is a dysfunctional component to it if we have plantar fasciosis, where essentially the plantar fascia pulls really tight on the bottom of the feet, which curls the toes. But largely, it's going to be due to poor footwear. And the last is going to be Morton's foot. That's the top image. And the reason I specify Morton's foot here is not because it's a problem, and it's defined as the second toe is longer than the first toe. It's not a postural dysfunction, but I mention it because there is something called Morton's Neuroma, which we have to be familiar with, which is very different than Morton's foot. An individual with Morton's foot has the potential of being more prone to hammered toe or claw foot, simply because the toes are longer and get pushed into the front of the shoes a little bit easier. But in and of itself, not an issue at all, which takes us into acute injuries. So before we jump into acute injuries, are there any questions about the postural dysfunctions?